Your doctor looked at your cholesterol results, nodded, and said the words most people desperately want to hear. Your numbers look fine. Total cholesterol under 200, LDL under 130, HDL decent. You left the appointment feeling reassured. You did the right thing. You got tested. Everything is normal. Half of all heart attack patients have normal cholesterol at the time of their event. Normal by the exact same standard your doctor just used to reassure you. That is not a fringe claim. That is data from the landmark INTER-HEART study, one of the largest cardiac risk studies ever conducted. The cholesterol test your doctor ordered is not lying to you deliberately. It is measuring the wrong thing. Total cholesterol and LDL are blunt instruments. They measure quantity, not danger. And in cardiovascular medicine, quantity without context is almost meaningless. I'm Dr. Arthur Sterling. Subscribe right now and hit like. What comes next will change how you read every blood test result you ever receive. To understand why the standard cholesterol test is inadequate, you need to understand what cholesterol actually is and what it actually does, because the version most people have been taught is dangerously incomplete. Cholesterol is not a poison. It is not a waste product. It is an essential molecule that your body manufactures deliberately in large quantities because it needs it. Every cell membrane in your body contains cholesterol. Every steroid hormone, testosterone, estrogen, cortisol, is synthesized from cholesterol. Vitamin D is synthesized from cholesterol. Bile acids that allow you to digest fat are made from cholesterol. Your brain is 25% cholesterol by dry weight. Your liver produces approximately 80% of the cholesterol in your bloodstream, regardless of what you eat. If you cut dietary cholesterol to zero, your liver simply produces more. Cholesterol is so essential that your body has a dedicated manufacturing system to ensure it never runs short. Cholesterol travels through the bloodstream inside carrier proteins called lipoproteins. Because cholesterol is a fat and blood is water-based, and fat and water do not mix. The lipoprotein is the vehicle, cholesterol is the cargo. LDL, low-density lipoprotein, is not bad cholesterol. It is a cholesterol delivery vehicle. HDL, high-density lipoprotein, is not good cholesterol. It is a cholesterol return vehicle. Calling them good and bad is a simplification so misleading that it has contributed directly to decades of mismanaged cardiovascular risk. The standard lipid panel measures the total amount of cholesterol being carried in LDL particles. What it does not measure, and what actually determines cardiovascular risk, is the size and number of those particles, the oxidation state of the cholesterol inside them, and the inflammatory condition of the arterial wall they are traveling through. A person with LDL of 140 carried in large, buoyant particles has a completely different cardiovascular risk profile from a person with LDL of 140 carried in small, dense particles, even though their standard cholesterol test looks identical. Here is what your standard cholesterol test is not telling you, and what it should be. The first thing it misses is LDL particle number and size. The standard test measures LDL cholesterol, the amount of cholesterol cargo. What determines whether that cargo damages your arteries is the particle itself, specifically how many LDL particles are present and how small they are. Small, dense LDL particles penetrate the arterial wall more easily than large, buoyant ones. They oxidize more readily. They trigger more inflammatory response. Two people with identical LDL cholesterol numbers can have particle counts that differ by a factor of 3 and cardiovascular risk that differs correspondingly. The test that measures this directly is called LDLP, LDL particle number, or alternatively ApoB, which counts the total number of LDL and VLDL particles in the blood. ApoB is now considered by many cardiologists to be the single most accurate predictor of cardiovascular risk available on a standard blood test. It is not on your standard lipid panel. You have to ask for it specifically. The second thing the standard test misses is lipoprotein A, written as LPA and pronounced LP(a). LPA is a modified form of LDL with an additional protein attached that makes it particularly adhesive to arterial walls and particularly resistant to the body's natural clot-dissolving mechanisms. LPA is present at elevated levels in approximately 20% of the population. It is almost entirely genetically determined. Diet and exercise have minimal effect on it. Elevated LPA independently doubles or triples cardiovascular risk, regardless of all other cholesterol numbers. It is almost never tested on a standard lipid panel. Most people with elevated LPA have no idea they have it, because nobody has checked. The third thing the standard test misses is oxidized LDL. The cholesterol in LDL particles does not cause arterial damage in its native state. LDL becomes dangerous when it is oxidized, when free radicals chemically alter the cholesterol molecules inside the particle. Oxidized LDL is taken up by immune cells in the arterial wall, triggering the inflammatory cascade that forms plaque. Standard LDL measurement does not distinguish between native LDL and oxidized LDL. The fourth thing the standard test misses is the inflammatory state of the arterial wall. Plaque does not form in healthy arteries regardless of cholesterol levels. It forms at sites of endothelial injury, where the arterial lining has been damaged by inflammation, by elevated blood sugar, by mechanical stress from high blood pressure. C-reactive protein, specifically high-sensitivity CRP, measures the level of systemic inflammation in the arterial wall. The Jupiter trial showed that people with normal LDL but elevated hs-CRP had significantly higher cardiovascular event rates than people with elevated LDL but low hs-CRP. The inflammation mattered more than the cholesterol quantity. This finding restructured how cardiologists think about risk, but it has not yet restructured what most general practitioners order on an annual blood panel. Now let me say something about statins, because this is where the stakes become highest and where the conversation most needs nuance. Statins are among the most prescribed medications in the world. Approximately 40 million Americans take them. They work by inhibiting an enzyme in the liver called HMG-CoA reductase, reducing the liver's cholesterol production and lowering LDL. In specific populations, people who have already had a cardiac event, people with familial hypercholesterolemia, the evidence for statins reducing cardiovascular events is robust, and the benefit clearly outweighs the risk. For people with no prior cardiac event and no familial hypercholesterolemia, so-called primary prevention, the evidence for statins is substantially weaker than most patients are told. A 2010 meta-analysis in the Archives of Internal Medicine found that statin therapy in primary prevention did not significantly reduce all-cause mortality. This does not mean statins are ineffective. It means they are most effective in the specific population for whom they were designed, secondary prevention, and significantly less effective as a blanket intervention for anyone with an elevated LDL number. Statins lower LDL cholesterol reliably. They do not address LDL particle size, ApoB, LPA, oxidized LDL, or arterial inflammation, the markers that most accurately predict cardiovascular events. A statin that lowers your LDL from 150 to 95 while leaving your small dense particle count, your LPA, and your hs-CRP unchanged has addressed the number without necessarily addressing the risk. Let me tell you about a patient I will call Edward. 56 years old, accountant. He came to see me after his cardiologist had recommended starting a statin. His total cholesterol was 218. His LDL was 142. His HDL was 52. His triglycerides were 95. By standard guidelines, he was a borderline case. Not dramatically elevated, but in the range where statins are commonly recommended. He was otherwise healthy, non-smoker, normal blood pressure, no family history of early cardiac disease. He wanted a second opinion before committing to a daily medication he had been told he might need for life. I ordered a complete cardiovascular risk panel: ApoB, LDLP, LPA, HSCRP, fasting insulin, and oxidized LDL. His ApoB came back elevated, consistent with a high, small dense LDL particle count, despite his moderate standard LDL number. His LPA was 78 nanomoles per litre, significantly above the threshold of 30 that indicates elevated risk. His HSCRP was 0.4, reassuringly low, indicating minimal arterial inflammation. The picture was more nuanced than his standard panel had shown. He had genuine risk factors, the particle profile and the LPA, that his standard test had completely missed. And he had a reassuring finding, the low inflammation, that suggested his arterial wall was currently healthy despite the adverse particle profile. The statin would have lowered his LDL number. It would not have addressed his LPA, which is not responsive to statins. The intervention that most needed to happen was identifying the LPA, informing Edward that it was largely genetic and that his children should be tested, and implementing the lifestyle and pharmacological approaches specifically effective for LPA reduction. Edward left with a complete picture of his actual risk, not a number reassurance and not a prescription. He left with information. Here is what a complete cardiovascular risk assessment actually looks like, and what you should ask for by name at your next blood draw. The standard lipid panel, total cholesterol, LDL, HDL, triglycerides, is the starting point, not the conclusion. Beyond it, the tests that provide meaningful additional information are these. ApoB. Apolipoprotein B counts the total number of atherogenic particles in your blood. It is a better predictor of cardiovascular risk than LDL cholesterol in most studies that have compared them directly. Request ApoB specifically. In most laboratories, it costs under $30 and is available without special authorization. If your LDL is normal, but your ApoB is elevated, you have more atherogenic particles than your LDL number suggests. LPA, lipoprotein a, should be measured once in every adult's lifetime. Because it is genetically determined and does not change significantly with lifestyle or standard medication, it only needs to be measured once. If your LPA is above 30 nanomoles per litre, or above 75 milligrams per deciliter, depending on the units your lab uses, you have a genetic cardiovascular risk factor that is independent of everything else on your panel. Your cardiologist needs to know this. Your children may need to be tested. High sensitivity CRP measures arterial inflammation. This is the fire in the wall, the inflammatory state that determines whether cholesterol deposits into plaque or passes through harmlessly. An HSCRP above 2.0 milligrams per litre in the context of cardiovascular risk assessment warrants attention, regardless of cholesterol numbers. An HSCRP below 1.0 is reassuring. It suggests the arterial environment is not currently primed for plaque formation. Fasting insulin, not just fasting glucose, measures insulin resistance, the metabolic state that drives small dense LDL production, triglyceride elevation,
and arterial inflammation simultaneously. A fasting insulin above 10 UIU per milliliter indicates insulin resistance that is driving cardiovascular risk through multiple pathways simultaneously, none of which are captured by the standard lipid panel. The standard cholesterol test costs approximately $15 and takes 30 seconds to review.
The complete cardiovascular risk panel I described, ApoB, Lp(a), hsCRP, fasting insulin, costs approximately $80 to $120 additional and takes 15 minutes to interpret properly. In the 7-minute appointment model that governs most primary care interactions, that 15 minutes does not exist. The system defaults to the $15 test, not because it is adequate, but because the appointment structure does not accommodate the alternative. Millions of people are reassured by a normal cholesterol number, while their ApoB, their Lp(a), and their insulin resistance continue to build cardiovascular risk that will not appear on their standard panel until it appears in an emergency room. This is not conspiracy, this is arithmetic, and it is exactly why this channel exists. The behavioral interventions with the strongest evidence for improving the complete cardiovascular risk picture, not just LDL, are these. Reducing refined carbohydrate and sugar intake lowers small dense LDL particle count, reduces triglycerides, and improves fasting insulin more effectively than reducing dietary fat in most people. The dietary intervention that most consistently improves the complete cardiovascular risk picture is not a low-fat diet, it is a low-refined carbohydrate diet. Cardiovascular disease remains the leading cause of death in the United States, responsible for approximately 1 in every 3 deaths. The majority of first cardiac events occur in people whose standard cholesterol panel did not flag them as high risk. After 50, the gap between what the standard test shows and what is actually happening in the arterial wall widens. As particle profiles shift, as insulin resistance becomes more prevalent, and as the Lp(a) that was always present begins to have more years of cumulative effect. How old are you? Write it in the comments right now. I want to know who is watching, because the cholesterol conversation at 48 is different from the conversation at 67. And what I cover next will be shaped by exactly where you are. Here is your action plan. At your next blood draw, request ApoB, Lp(a), high-sensitivity CRP, and fasting insulin. If your doctor declines, these tests are available directly through consumer laboratory services for under $100. If your Lp(a) comes back elevated, ask for a cardiology referral specifically for Lp(a) management. If your ApoB is elevated with normal LDL, do not accept reassurance based on the LDL number alone. Your cholesterol number is not a lie, it is an incomplete sentence. I'm Dr. Arthur Sterling. I have spent 15 years watching patients be reassured by a number that was not telling the whole story. Subscribe, hit like, and send this to someone whose heart you want to protect. The pharmaceutical system profits from prescribing to a number. I profit from understanding the complete picture behind it.